Hi, everyone. Thanks for joining us. My name is Elena Prager. I'm an assistant professor of economics at Simon nowadays. And for those who are curious, I teach the core MBA data analytics class. So some of you in the audience, I'm sure, already know that from having interacted with me in that capacity. But today, what I'm here to talk about is a topic that's sort of near and dear to my academic heart, something I began working on way back at the start of my PhD dissertation, which is whether and how we can get more for our healthcare dollars by designing health insurance plans smarter. And I'm going to focus today's remarks on just private healthcare dollars, so you should have in mind primarily employer-sponsored health plans and to a lesser degree Obamacare exchange plans, not publicly financed insurance, so not Medicare, not Medicaid. Now, insurance plan design broadly has two levers for encouraging more efficient use of healthcare dollars. The first lever is constraints and incentives for providers. So these are physicians, nurses, hospitals, and those constraints and incentives include things like prior authorization, where certain expensive treatments might require pre-approval. The second lever, which is actually the subject of today's presentation, is constraints and incentives not for providers, but for patients. And these are usually going to be in the form of cost sharing, meaning the insurer requires the patient to spend money out of their own pocket in order to access certain healthcare. I'm talking about things like co-pays, co-insurance, deductibles, and other related cost sharing tools. Now, as a nation, you may be aware we spend 18%, 1/8 of GDP on healthcare, and that percentage continues to grow. Increasingly, insurers and employers are sort of farming out some of that spending into out-of-pocket spending by patients. So between 2016 and 2021, as you can see on this plot, total national out-of-pocket spending grew from $300 billion a year to just under $500 billion a year, which is a 65% increase. That's a substantial increase. And many of us, I think, have personally experienced this growth in what we're expected to pay out of our own pockets, even after we've paid for premiums. Or if you personally are lucky enough not to have experienced this, probably your older or less healthy loved ones have. Some of this increase in out-of-pocket spend could be explained by insurers and employers shifting costs onto patients just because they can, some of it. But crucially, the point I want to make today is that not all of it can be explained by that. There are actually some good reasons to ask patients to pay something for some of the care that they get. And what I want to do is walk you through a scenario where this logic works particularly well. So let's take a patient in a self-insured employer's health plan who needs a routine colonoscopy. And let's say that the patient's nearest hospital, the one I have on the left here, is a 10-minute drive from her home. And if she gets her colonoscopy there, the total cost is going to be $2,300. Now, suppose if she drives an extra 5 minutes to the next nearest hospital, that's the one on the right of the slide, the cost will be just $900 because hospitals have different prices attached. Without any cost sharing, the patient really has no reason to go to the farther hospital, so she'll get her colonoscopy probably at the $2,300 hospital. Now imagine introducing modest cost sharing for the more expensive hospital, say maybe $100 out of pocket to go to that one, and $0 or even something small like $50 to go to the slightly farther but less expensive hospital. Now there's a good chance this patient will go to the less expensive hospital, and that saves the system as a whole $1,400, which the employer can then use either to charge employees less in upfront insurance premiums, so good for patients, or to, for example, provide more generous coverage for some other kind of healthcare, also can be good for patients. Now, because there's such wide price variation in prices across healthcare providers in the United States, not necessarily true in other countries, in the US, these kinds of plan designs can be genuinely useful for improving bang for buck. So that's sort of the case in favor of cost sharing. It gives patients some skin in the game and may reallocate them to more efficient use of healthcare dollars. But while some skin in the game can be useful, that doesn't mean more skin in the game is necessarily better, right? An important goal of health insurance is to insulate people from crippling medical expenditures, and too much patient cost sharing can undermine that goal. So just to give you some context, nearly 1 in 5 Americans have outstanding medical debt. And among those people who have any, the average debt is $2,400, which compared to most people's incomes, that's a substantial sum. It's probably small wonder then that nearly 1 in 10 Americans report either delaying or sometimes altogether foregoing some medical care because they feel they can't afford it. But even patient cost sharing that falls short of being truly financially burdensome doesn't necessarily have to be beneficial. Some cost sharing accomplishes basically nothing except to shift healthcare spending onto individual patients or onto their families, instead of having the spending be paid for by a larger pool, like an employer or the small group market. And those larger groups, like employers or like the exchanges, they're much better suited to absorbing and spreading risk than a given family is, because having a large group is like having a diversified investment portfolio. The risks get smoothed out and no one family is exposed to a ton of risk the way that you would be if you put all of your money into one single stock. So the real problem with many cost sharing designs is that they both fail to move total spending. So they fail to actually achieve the goal of improving bang for buck. And at the same time, they expose patients to extra risk. So basically, there's no benefit, but for the patients, it's all cost. So we've established so far that cost sharing can be useful, but it also can be useless or even harmful sometimes. Where's the sweet spot? Well, in an ideal cost sharing design, you would simultaneously achieve 2 goals. First, the ideal design would reduce overall spending by nudging patients toward more cost-effective treatments or providers. And then the spending reduction could be used to finance cheaper premiums for patients or more generous coverage of other healthcare or something useful. Second, the ideal cost-sharing design would protect patients from financial risk by making sure they don't have to pay out of pocket when they really need treatment. The trouble is, you really can't do both of those things at once. You can't both make care free to patients and at the same time expect to be able to nudge them toward more cost-effective options. So we have to settle for the best achievable alternative instead of this theoretical ideal that I've painted for you. That means necessarily we accept some financial risk to patients, but only if we get something valuable back in exchange for that risk. In other words, we should only use cost-sharing designs that are actually effective at reducing overall healthcare spending. Otherwise, we shouldn't be using them. I find it useful as part of this exercise to visualize how ideal, achievable, and then just plain bad designs fit together. Remember, the ideal design saves the system lots of money, so it's on the right side of this chart, and it exposes patients to minimal financial risk, so it's on the bottom of this chart. A design that instead exposes patients to lots of risk but doesn't save any money is on the top left of this chart and is just a bad design. Where we can make progress is on the top right of this chart, where the best achievable designs live. They do expose patients to some risk, yes, but they save the system money that can then be diverted to other helpful uses. Now, before I can finally tell you which designs have been shown to work well and which ones not, I have to establish a little bit of common language so that we all sort of agree on what I'm talking about. So I've put here on this slide a list of some of the most common types of cost-sharing designs, and some that should be common because they work well, but aren't. The first here is high deductible. High deductibles are a cost-sharing design that requires the patient to meet a deductible before their insurance plan coverage kicks in. So they have to pay, say, the first $2,000 or $4,000 of healthcare spending in each plan year before their insurance starts to kick in. That's supposed to nudge patients toward cheaper treatments or providers, but of course, in practice, it's really hard for patients to follow those nudges unless they know in advance what every option costs. Moving on to coinsurance, coinsurance is a cost-sharing design that requires the patient to pay some percentage of the total price for each service. So say with 10% coinsurance, a patient would pay $50 for a treatment that costs $500 total, but if the treatment costs $900 total, the patient will pay $90. And that also is supposed to nudge patients toward the cheaper options. Next, we have price transparency tools. They're really like a health plan design add-on that's meant to help patients navigate the first two designs by allowing them to look up in advance what the price of a given treatment is with a given provider. But as we now know from research, in the real world, price transparency tools often fall short of their intention to make prices simple and predictable for patients. Moving on to reference pricing. This is a cost-sharing design that sets some baseline price level for a healthcare service, let's say $900 for a colonoscopy, and then requires patients to pay only whatever portion of a provider's price is above that $900 baseline. So if you get a colonoscopy from a provider where it costs $1,100, the insurance plan will pay the first $900, but then you'll be required to pay the remaining $200. And again, that's supposed to nudge patients to get their colonoscopies from the cheaper providers. Finally, my favorite plan design, tiered networks with copays, are a cost-sharing design that groups providers into 2 or 3 bins depending on their cost, and then tells patients which providers are in which bins and what they will have to pay out of pocket for each bin without having to look up any additional information or know exactly which treatment they're going to get. So now that we've established some common language, which of these cost-sharing designs are candidates for best achievable and which ones are just plain bad? Well, honestly, for the past 30 or 40 years, even people who study these questions had very little understanding of which designs work and why those work and others don't. And in the absence of good evidence-based knowledge, we turned instead to abstract theory. And what that meant was that these overly simplistic economic theories led economists to believe that deductibles were the platonic ideal form of cost sharing, that they were sort of the optimal thing that you could do in an economic model. But now we actually know that not all cost sharing designs are created equal. And rigorous research has shown that the last 2 cost sharing designs from the previous slide, so reference pricing and tiered networks, do succeed at reducing overall health spending, whereas others really don't. Unfortunately, that cutting edge research, which I'll tell you a little bit more about starting on the next slide, it really hasn't diffused into how employers and insurers design their health insurance plans. So there's still great reliance on things that we now know don't work, especially things like high deductibles. Now, there's sound academic research supporting sort of the complete ranking that I gave on the previous slide, but I only have 20 minutes. So I'm going to focus on the research for just one of the plan designs to give you a flavor of how we know these things. And I'm going to focus on tiered networks and some of my own work on them. Now, a tiered network, like any provider network, begins with a health insurer negotiating prices with providers in the market. So as a simplified example, take this small market, it's got 4 hospitals and the insurer has negotiated different prices with them. The next thing the insurer will do is bin these hospitals into so-called tiers. The lowest priced, darkest blue hospitals are going to go in tier 1. The middle priced medium blue hospital will go in tier 2. And finally, the highest priced light blue hospital goes in tier 3. And then patients will pay different amounts out of pocket if they get inpatient hospital care at a tier 1 hospital than if they get it at a tier 3 hospital. The idea is that this is supposed to nudge patients toward tier 1 hospitals, which saves the whole system more money than the difference that the patient is paying out of pocket. Designs like this one make shopping for healthcare comparable to shopping in a grocery store, because what patients will be shown is something like the screen grabs that are on this slide. They're going to see which hospitals are in which tier and what total out-of-pocket price is associated with each of those tiers. So basically, they're seeing the price of every product, meaning hospital, all at once, and they're seeing these prices before rather than after they've already gotten the healthcare, which is normally how people find out what their healthcare costs. Moreover, the price doesn't change after the fact if it turns out that the patient has complications requiring additional care or just a different treatment variation from what was initially planned. With coinsurance or deductibles, so those bad designs that I mentioned a couple of slides back, changes in the treatment plan or complications end up affecting the patient's out-of-pocket payment, even if there's no way the patient could have anticipated or predicted them in advance, which makes those kinds of plan designs much, much harder for patients to navigate. So recent research, like research on tiered networks, tells us that these kinds of financial nudges only work if they are designed to be user-friendly. And traditionally, I probably don't have to tell you, healthcare prices and health insurance have not been user-friendly. So for example, here's a screenshot from the plan documentation for an insurance plan offered by a large employer. It's not the U of R, in case you're curious. There are 3 columns here for 3 sets of providers, and each column describes different cost-sharing design details. Now, there's no list of which providers are in-network versus out-of-network or part of the preferred network. Patients have to look up that stuff themselves after logging into a separate website every time they try to figure out where to go for care. And even if they do figure out which providers belong in each of these columns, they still don't know, for example, the provider's total prices from which this 20% coinsurance will be calculated. And they're not going to know, for example, whether the price falls below or above the deductible, which would tell them whether it's worth shopping around more or not. So what I'm trying to illustrate here is that designs like this are just too complicated. They're asking too much of patients. They make it too hard to figure out what a patient is going to have to pay for each provider. And the evidence shows that as a result, maybe not surprisingly, they don't actually help patients pick lower priced providers. All they do is scare patients into getting less healthcare overall, including less of care that medical professionals widely agree is high value and cost effective. So this is things like regular vaccination, which we really should not be discouraging people from getting. That message that only certain types of health insurance designs actually work for nudging patients and that they have to be really simple and really easy for patients to navigate has not gotten through to insurance designers. High deductible, one of my key examples of not great plan designs, remain one of the most common cost-sharing designs still. In the 10 years after 2006, as you can see on this plot, the market share of high deductible health plans among patients insured through an employer grew from 5 to 30%, and it has stayed stubbornly high around 30%, even after we learned several years ago that high deductibles don't actually work for getting patients to shop. Worse yet, high deductible health plans have an even larger market share on the Obamacare exchanges, probably above 50% by the best estimates that I can find. So, if this has been a call to arms for anything, it's been a call to arms for transitioning away from these ineffective cost-sharing designs like high deductibles, like coinsurance. Following the science in this setting means transitioning away from the cost-sharing designs that fail to reduce total spending. I would say insurers need to shift toward effective designs, or at least away from the ones that we now know are not effective. And employers have a role to play too, those that are large enough to have the scale and the bandwidth to think about insurance plan design should demand simpler designs from their insurers. Now, of course, many small employers don't have the expertise or bandwidth to advocate for better insurance designs, but large employers could make a substantial dent all on their own because they represent a disproportionate fraction of insured patients. Now, I don't mean to excuse people like myself from this. Researchers and economists also need to do better on this. Early research by economists concluded that deductibles are the optimal class of cost-sharing designs, and that's one of the reasons we ended up with deductibles being so ubiquitous. But the economic theories that produced that conclusion are sort of akin to physics models that assume that all objects are perfect spheres traveling through a frictionless vacuum. Useful, informative abstractions that help you predict the trajectory of a falling object, but are woefully unequipped to do things like designing effective parachutes. The economic models that gave rise to this flawed conclusion that deductibles are the optimal class of cost-sharing designs assume that there exists only one kind of health problem, only one kind of illness, and that it can be treated with only one kind of treatment, ignoring the fact that patients can get sick with different things. There are often multiple treatment modalities available, and there's a lot of uncertainty about which treatment or drug is going to work best for a given patient. So, of course, we shouldn't expect idealized models to give us the right answers for how to design cost sharing in our much more complex real world. In a real life setting, we now know that simple, comprehensible cost sharing designs, even if they look cruder than designs with high deductibles or coinsurance that are sort of more sensitive to the underlying price distribution, those simple, comprehensible cost sharing designs do much better. Thanks so much for your attention. I'm going to stop here and we are going to transition to Q&A. Let me just go through what has been asked. Okay, we've got a great question from Michael Camiolo. Aren't hospitals different value leaders in different categories? For example, one hospital has an expensive ER visits, but cheap colonoscopies. This is absolutely true. And this is actually one of the arguments that people make against simplified designs like tiered networks. So they'll say, look, different providers are good for different things. They're efficient at different things. And therefore, it oversimplifies things to just tell patients, this hospital is $200 no matter what you get. And that hospital is $700 no matter what you get. And we should sort of have price schedules for patients that are more sensitive to the underlying differences across hospitals. I'm sympathetic to that concern. The trouble is that once you start segmenting the price schedule as a function of what the patient needs, it very quickly becomes unmanageable for the patients. So very quickly, you get into a situation where the patient is back in the world where they have to try to be a healthcare expert in order to figure out what price they're going to be expected to pay out of pocket. So I think there's a trade-off here between how sophisticated and how sensitive can you make the plan design to the underlying prices, like Michael is suggesting, versus how do you make the design simple enough that patients can even respond to it at all? Because if you overload people with information, then they stop responding altogether, and that's not useful either. Okay, let's take another. Here's a question that speaks to my economist roots from Linda Salman. Apologies for any mispronunciation. Linda asks, would these simpler designs be more or less profitable for the insurance industry? You know, I think this is in part going to be driven by whether employers are playing an activist role in transitioning us to these simpler designs, right? Because if insurers just unilaterally say, okay, we're not going to do high deductibles anymore, we're not going to do coinsurance anymore, we'll put everybody on reference pricing or tiered networks or something equally simple, then what'll happen is that you'll reduce the out-of-pocket costs that patients are paying and shift those costs back onto the insurer or back onto the employer, which in a world where nothing else changes and nothing else responds, could indeed be less profitable for the insurer. Now, if employers are at all savvy about this, they will see that this can save the system as a whole money. And so they will demand from insurers the introduction of these kinds of plan features. And so you really need to have insurers competing with one another in order to compete away the worst plan designs and compete in the best plan designs. And without sort of putting more structure on how we think insurer competition works, because of course it varies by market, it's very hard to give a straight answer that'll just go one way or the other reliably. And sorry for the break, just reading through other questions here. Sorry, everyone, there's a lot. Okay, Tom Kellerhouse asks, are there providers or payers you can point to as examples of getting this right, like tiered networks with upfront pricing information? Oddly enough, I feel like the leaders in this space have been large public employer HR groups. So the CalPERS system, which is the system that manages health insurance and other sort of associated, retirement benefits and things like that for the state employees in California, has had a very successful track record of implementing reference pricing in their insurance plans for their employees. And the Massachusetts Group Insurance Commission, which is sort of the parallel to CalPERS in Massachusetts, has an excellent track record of implementing tiered networks. And often, actually in both cases of those state agencies, these initiatives have been paired with very strong communication to their employees and sort of member education campaigns so that the patients understand what kind of plan design they're being exposed to. And as far as I understand, those patient education campaigns have also been very important in getting these things to work successfully. Let's see. Scott Beaudry asks, what about the costs associated with creating the tiers? Honestly, in my experience working with insurance companies, that's the easy part. The insurers know what prices they've negotiated with the various providers. They know what quality metrics they want to use in order to, for example, disqualify certain providers from the most favorable tier placement. And they just, you write a very quick algorithm, you can do it in a day or two that will bin providers into these tiers. I would say the costs of the actual tiering are relatively minimal. It's the costs of educating the providers and educating the patients, like those state agencies have done, that probably add up. And if I were a bigger expert on sort of the sociology of this rather than just the economics, then maybe I could give you an estimate for what those information and campaign costs look like, but I don't unfortunately have a good sense. Jean Ryan asks, how does this ideal design framework change if we don't accept the initial premise that various providers will or should have wildly different costs for care? Is this just inachievable or impossible to influence here in the US at this point? So I'm going to read between the lines a little bit and assume that this is a question getting at whether single payer healthcare is achievable, which would come with dictating a price schedule that is the same across providers. For example, Medicare does this. They very famously do not do this for pharmaceutical drugs, but for example, hospitals or physicians. Medicare essentially sets a price schedule. It's got some inflation and deflation factors depending on, for example, local costs. So they'll pay more if you're in a really high cost area like New York City and pay less in Western New York. As well as some adjustments for things like, is this a training hospital that's sort of providing teaching services? And that's something that we want to make sure that we keep paying for so that the system will keep producing new doctors. And to me, this is a political question. I think we've seen very little evidence in the last, let's say, 13 years since the passage of the Affordable Care Act, which was the largest piece of health reform legislation in decades, really, that there is sufficient political appetite to move in the direction of single payer. Now, I'm not a politics expert, so I'm reading the tea leaves here, but I don't think that there is enthusiasm even from the bulk of the Democratic Party, and certainly not enthusiasm from the Republican Party. And so going out on a bit of a limb, because again, this is outside my real area of expertise, it does not seem likely to me in the foreseeable future, but things develop in unpredictable ways sometimes, so who's to say? Well, I was going to read through some more questions, but I see we are actually at time. It is 12:30 Eastern, so thank you all so much for joining us, and hopefully see you at the next one.